I do have a tendency to talk faster than I flip my slides, so if all of a sudden I'm talking about something that's not up there, somebody wave at me. I'm a parent like a lot of you, so I deal with that. My children are 18 and 21, so they're grown. I got involved with the American Nystagmus Network through a colleague who said, hey, this looks like it's right up your alley, and I had done a lot of work with nystagmus patients. So one of the big questions I get is, what else can we do? And I do vision therapy for patients without nystagmus, as well as vision therapy for patients with nystagmus. And we fight the same fight that Dr. Hurdle was talking about, that I asked him about, and that is the ophthalmology population in the United States are not fans of vision therapy. I've heard, we don't believe in vision therapy doesn't do anything, there's no such thing as vision therapy. And I equate it to the orthopedic surgeon telling you there's no such thing as physical therapy. But we all know that physical therapy is a tried and true profession. In this country, our physical therapists are now doctors of physical therapy instead of masters and bachelor's degrees. So it's a growing, more recognized field. They're now doctors. So it's unusual to me to think that this profession of surgeons thinks that vision therapy doesn't have a place. So you might come across that. You might ask your doctor, well, what do you think about vision therapy? And you might get that answer, oh, that's nothing, that's not going to help you. And it's really up to you to make your own decision, I think. So I was asked to speak about vision therapy. I don't know if any of you sat in on the researchers forum, but in other countries, pretty much all the nystagmus patients are either conferenced about or go through vision therapy. So it's not something that, the world does that is, hokey or that sort of thing. And if you have questions as we go along, I'm happy for you to interrupt me if it's pressing and you can't remember, because I'm that person that if I have that question and I have to wait till the end, I won't remember what I wanted to ask. If you have the question, chances are somebody else has the question as well. So we'll just go on from there. So when we look at vision therapy and when we decide to do vision therapy, there are some things that I need to know ahead of time, and that is, what is the binocular status? Is everybody familiar with what that means, binocular status? That means using your eyes together. So we have right eye channels, we have left eye channels, and then we have binocular channels. So you can see really good out of one eye and see 20/20 and be legally blind in the other eye. You can have next to no vision or reduced vision in the other eye, and that can impact your binocular status. Yes?
Is that different from depth perception?
Yes and no. So depth perception is being able to tell that things are different distances from you. And you can see depth perception in a flat painting or a photograph because of overlay. So when you overlay somebody in front of somebody else. So when I close this eye, I can tell that you're in front of the gentleman behind you, who's in front of the gentleman behind him. So we have some depth perception. Binocular vision is when you use the two eyes together and you can tell how far something is. So it's stereo vision, binocular vision, which is a little bit different than depth perception. So stereo vision, like stereo sound, is a fuller, richer picture. Stereo sound is a fuller, richer sound. So if you remember AM radio, or some of you old enough to remember AM radio, and then you go to FM radio, right? It just sounds full and rich. So when you have monocular vision, if you all just cover one eye, it's not like you can't see, right? It just seems sort of odd. And when you look with both eyes, if you're binocular, that picture just sort of comes to life. So that's the difference. So we look at binocular status because this impacts how we do vision therapy. Is there a hyphoria present? So phoria is a tendency for your eye to drift in or out. It doesn't actually turn unless you cover an eye and then it drifts under the cover, which way it normally wants to be. So when we switch back and forth, we might see the eyes move a little bit, or a lot, or not at all. And that gives us an idea of what your phoria is and more information about your binocular status. Is there atropia, which is really an eye turn, or strabismus? So those are terms you may or may not have heard. Strabismus is the garden variety term that says an eye turns. Your eye can turn up or down, in or out, or rotational. So atropia is kind of our shortcut version. It's just another name for strabismus. But when we designate what type of strabismus you have, we say ESO for in, exo for out. So we say esotropia, exotropia. We don't say esostrabismus and exostrabismus. So that's where that term comes from. Is it constant or intermittent? Because that also impacts how we decide what kind of and how much vision therapy we think we're going to need. Is there suppression? So that means, does one of your eyes shut off? So maybe you have an eye turn, but you don't see double because the brain shuts off that eye. Sometimes you can have intermittent or constant suppression. Sometimes you can have central suppression and peripheral fusion, which means you have peripheral depth perception but not central depth perception. And sometimes you can have complete suppression. So those are the important things that we need to know. And are these terms all new to you guys? Are you a little bit familiar with it? Is there any questions about that? Okay. So the other thing I need to know is what kind of correction that you wear. Are you wearing a full correction? Because what we find in nystagmus patients is that a lot of times they're not wearing the full correction, and Dr. Hurl mentioned something about this before. Like if you have 8 diopters of astigmatism or cylinder, maybe the doctor who prescribed for you only gave you 2 or 4 or 6. And why do we do that? And we do that for what we would consider normally sighted patients. Perhaps giving you more astigmatism doesn't increase your visual acuity, and it can increase distortion and balance, cause balance issues and things like that. And so we cut prescriptions until we see a drop in acuity. And we find that's not very good for nystagmus patients. We find that giving you the full maximum correction, although I might not measure better visual acuity, you will tell me, I see better. And so we pay more attention to what you tell us. Well, no, I see better with this. And you know, it is that thing that everybody wants to know, what's your acuity? It's one of the first things I ask, but it's not the only answer, and it's not the full answer by far. So if you're not wearing the full correction, I would put you in the full correction before we started vision therapy. Do you have prism in your correction? And are you all pretty familiar with prism? Yes, no? We use prism to sometimes help you reposition your null point. Sometimes if the eyes aren't working together, the prism can help your eyes to work together. So there's a lot of varying reasons why we would put prism in, and that's part of knowing what your binocular status is. And then are you wearing a near ad or a bifocal? And so for any of you who are over 45-ish, you might already be in bifocals, but a lot of times we'll put bifocals on younger patients who have reduced vision because it helps them, and there are varying reasons other than just that way we might put somebody in a bifocal, but that also affects what we think we might do as far as vision therapy is concerned. And then if you're wearing contact lenses, and the same thing with contacts, is it a full correction? Is it a partial correction? What kind of contact lenses you're wearing? So we don't just jump into vision therapy and say, oh, we can do it. We need to know all of these kinds of things. So when you're looking at that, it's important to have all of these answers ahead of time. So traditionally, and so let's talk not nystagmus patients and just regular vision therapy. Our goal is single, clear, comfortable binocular vision. It doesn't say 20/20. So even patients who don't have nystagmus, our goal is not 20/20 vision. Our goal is single, clear, comfortable binocular vision. And we say binocular because we know that the visual system works better when you use 2 eyes together. You can have 20/30 in one eye and 20/30 in the other eye, and when you put them together, you can have 20/20 with both eyes together. And so we know that happens, and so our goal is to maximize whatever vision you have, and if we can get you binocular, we know we're going to get better results. So when we look at vision therapy, we look at eye teaming, eye tracking, eye focusing. And there's other types of vision therapy that have to do with visual processing, and I'm not really going to be talking about that at this particular lecture, but if you have questions about that, I will be around this evening. We're going to join you for dinner in the social, and please feel free to come up and ask me if you have more specific questions. But we're really looking at eye teaming, eye tracking, and eye focusing, because this helps your functional vision. It helps you navigate in the real world. So of those 3, can you actually do the task? And if you can't do the task, then those are things we start with. Stamina, how long can you do the task? Because I think for a lot of patients who have nystagmus, they can do tasks, but for very short periods of time. The eyes get tired, this visual system gets stressed, and so can we do something to mitigate that and give you increased stamina? and what the flexibility is, because you might be able to do something here and you might be able to do something there, but you can't go back and forth. And so for the real world, where we're constantly looking close to far, far to close, that flexibility is important, and the faster you can change your gaze, the better off your functional vision is going to be. So, a lot of the complaints I get is like, I can see this and I can see it clear, and then I look up and it takes me a long time, but once I hone in on it, then I can do that, and then I come back and I've lost my place. And so we look at that flexibility, and that is just the way our visual system works. We need to have that kind of flexibility. So that's important when we talk about vision therapy. So we talked a little bit about suppression. So you can't be binocular if you're suppressing. So if you are suppressing, then we want to look at some anti-suppression therapy. This is where we see the greatest risks for adults, and something that we need to consider, and that is, are we going to cause you to see double? And what kind of impact does that have on you? Because when you suppress the vision, you're not going to see double, you're only using one eye. But we know if we can get you to use the two eyes together, it's going to be better. So we weigh risks, we weigh the risks against the benefits, and then we go forward. And this is not a decision I make, it's a decision I make in conjunction with the adult patient. And I say the adult patient because for kids, if I make them double, and we can't fix anything else, their systems are young enough and pliable enough that they'll learn to shut that eye down, in most cases. In adults, once we make you see double, if we can't get you binocular, you can end up with double vision the rest of your life, and that can be very, very disconcerting. And so this is a discussion that's really important to go through, and that is, what are those kinds of risks? Dr. Hurdle was talking about, if you see double, then we can just move the muscle and move it back to where it is, and your eye will shut it down, and that is our hope. We have had some cases, not with surgery, but with vision therapy, where we can't shut that double vision off. And so it's not something that we take lightly. We take that very seriously, and it has to be a risk that you're willing to take if you're going to go through it as an adult. There are some cases where older kids, tweens, might get intractable diplopia, and so it's a discussion we have even with parents, even though we know the risks are much more reduced when you're younger. Of course, the benefit is, if we get you binocular, your vision is going to be better. So in traditional vision therapy, we look at eye teaming. Do the eyes work together? And what can we do to teach the eyes to work together? And so this is designed to show you some basic things that we do in vision therapy. So, if you talk to any optometrist who's a vision therapist, they should be familiar with these kinds of things. So there's a list of them: pencil push-ups, rock string, 3-dot cards, vector graphs, and eccentric circles. And I actually have pictures of them to show you. And thank you to my 18-year-old daughter. At the 11th hour, I said, I need pictures, so help me out. Pencil push-ups. So we just take something and we bring it as close as you can, and we track the eyes to see if they converge. And if you all do this, do you know if you all can cross your eyes? And if you can cross your eyes and see one target here and everything else in the background is double, that's the way it's supposed to look, then you can converge, okay? And if you can't, we can teach you, and we start off at whatever distance you can converge and work your way in. And so the Brock string is a really long string. I also have some examples of these, so later on, will you hand me my folder in there? You can come up and play with it and see what you're doing. It's the manila folder.
There it is, at the back, of course.
Yeah. Sorry about that. So you can't see it on this, but toys. So you can see it's very long. So if somebody is, if you hold the end of that string for me, double out to 8 feet, 10 feet, we can work the full length of this. And so you don't just have to have near point problems, you can have distance problems, and we can do vision therapy for that as well. And there's particular ways that you use this to help use the eyes together, and the string gives you feedback, because if you were to look at this bead, if you hold it up to your nose, if you were to look at this bead, what you look at is single and everything else is double. So the string coming away from the bead and the string going towards the bead is double. So this is really great for somebody who's old enough to understand. It gives you personal feedback, and it's something that you can do by yourself. Do you see that? Yeah. You kind of see an X and it should cross right at the bead. And if it crosses in front of or behind the bead, that means you're not very accurate. And so you can work your way to becoming accurate. So it's nice to have that kind of feedback. So the next one is a 3-dot card. So this is much, much closer, but it helps you with accuracy because the card is very, very thin. So if your two eyes that are looking at the card are not exactly in the same place, you won't get the right effect. So this is one of those that we work accuracy for. Vectographs, which are stereo, I don't know if any of you have seen this. It's kind of a double image. I don't know if you can see it here. I'll hold it up against the light. It's kind of a double image, and they'll look 3D, and they're 3D in different positions. And what we do is we slide them apart and slide them closer together. So if you can get 3D and we slide them apart, your eyes work stronger, and it helps you with the accuracy as well. So that's also related to eye teaming. Eccentric circles, this is a much, much higher level. When you hold them and you cross your eyes, you see a 3D third set of images in between. So this is some of that more traditional vision therapy. So for focusing, patients who have reduced visual acuity tend to have weak focusing systems because the stimulus to focus is blur. When you have reduced acuity, everything is just a little bit blurry. And so the stimulus to focus isn't really there. It's there when you're younger, but your brain has figured out that, well, I can do all this focusing and things don't get clearer, so it kind of stops doing that. And so what we have to do sometimes is we have to sort of kick it in the pants and teach your system how to refocus. And so we do focusing therapy. And then people who don't have reduced vision sometimes just have poor focusing ability. Something like 15 to 20% of the general population, so if you're in here and you don't have nystagmus and you're thinking, I have some of these problems, 20% of you probably do. It's natural to not have just automatic eye teaming, eye focusing, and eye tracking abilities. So we do monocular and binocular focusing tasks because each eye can focus individually, and then both eyes focus as a team. And sometimes each eye can focus together well, but they don't focus together as a team. And we want to make sure that we have all of those. So alphabet pencils. They're just fun pencils for the kids to use, and we take the pencil and hold it up. And so when you're looking at something that actually has a letter on it, as you bring it close, and because I'm over 45, when it gets to a certain point, it gets blurry. When you're young, you should be able to get it pretty much close to the end of your nose. And so we monitor how close you can get it. The closer you can get it, the stronger your focusing ability is. And how close can you get that, Claire? Yeah, because you're young. Okay. A heart chart, which is a very small chart with letters on it and a big one. You put the big one on the wall, you hold the small one, and you focus from close to far, and that works the flexibility because you need not only ability to focus but flexibility. Everything that you look at is a slightly different distance, and you want to be able to focus at those different distances. And accommodative flippers, so you can hold this at any distance, and one side is a plus prescription, which relaxes your focusing ability. The other side is a minus prescription, which activates your focusing ability, and we go back and forth. And so that's a flexibility at one distance versus the heart chart, which is a flexibility from close to far. So is that pretty clear for everybody? Eye tracking is just following the target. You know, the doctor says, watch my wand, and we have you watch it, and we just move it around, and we check your muscles, and then we see how well you focus. Can you keep your eye on the target as it gets moved around slowly? And then we work small distances and big distances. And I think this is an area where a lot of patients with nystagmus have difficulty doing is tracking, and we'll talk about that in a little bit. So these are called wolf wands. There's a pair. Do I have pictures of those? Nope. I inserted some pictures, but not everywhere. So we do alphabet pencils with tracking as well, because sometimes it's easier to follow a letter. You know what, you can keep, it keeps your attention better. And then we do sheets of letters and numbers, and we have you look back and forth at them. And unfortunately, I don't have pictures of those, but that's sort of a more traditional vision therapy. Most people think reading is a smooth movement where they just track along. Reading is actually a saccade, which is a small motor movement. It's actually a jump from word to word. And it's interesting that logically we think we read fairly smoothly, because when you read out loud, you read fairly fluently. But the eye movement is jump, 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 jump. And so when you don't have good tracking, you might overjump, skip a word, come back. So if you find that you have to read a line, come back and reread it, you skipped a couple words, or when you go from the end of the line back to the beginning of the next one, that you lose your place, you might skip. So you might skip words or lines as you're reading, so that's a motor tracking. And so we have some specific kinds of exercises to help you with those as well. And some of them are called Michigan tracking and random letters. Yes?
Do people with nystagmus, when they read, typically do their eyes would they get tired from trying to do that all the time? Or?
It varies.
Can you repeat the question, the recording?
Oh, sorry. The question was, do patients with nystagmus get more fatigue when they're reading? I think anybody who has reduced eye tracking, eye teaming, and eye focusing, and reduced visual acuity have more fatigue when they're reading. So you might know people who can read for 3-4 hours, not have any symptoms at all, and somebody who can only read for 10 minutes and they need to take a break. And that's not necessarily related to nystagmus, but I think most nystagmus patients have greater fatigue because they have reduced visual acuity and reduced eye teaming and eye tracking skills. So, yes, sort of.
I don't know how many people in the room have nystagmus, presumably most people, but what about a show of hands who gets fatigue when they do an extensive amount of reading? Is that a common thing?
Okay, so the question is, how many of you get fatigue from reading, regardless of whether or not you have nystagmus?
Depends on what it is. Computer versus paper is different.
Right.
Right.
And
Reading a book, I'll get tired. Computer, I can read for hours.
okay.
And sometimes content.
And sometimes what?
Content.
Content. Yes. Yes. The more interested you are, the more well, here's the thing, when it's related to content, it's not fatigue, it's interest. So you're fatigued, but you don't care because you're interested. And so we find that kids will sit down and play a video game, and it doesn't matter how fatigued they are, they'll still do it because they're more interested in what they're doing than the headache or eye strain that they're experiencing. It's just like athletes. I mean, how many athletes do you know who still perform injured or hurt? And it's because they want to. The desire is there, so you have to separate those things as well. So we took this vision therapy equation and we said, hey, instead of telling nystagmus patients, oh, so that's the vision you have, yeah, you're lucky for what you have and there's nothing else we can do, why don't we treat them like any other patient who has poor tracking, poor focusing, and poor eye teaming, and see what we can do? And the blowback I get from that is, well, but you're not going to make them see better, so why bother? And I think you're all here because you do bother. You know, you are bothered by that. Let's do something else. Our goal is a little bit different. We want to maximize your vision and search strategies by increasing your binocular vision, your spotting skills, and your foveation. And this is a new term, and give me a second and I'll talk about that. So we're not looking at improving your visual acuity, but I think there's a lot we can improve. And I sat through Dr. Hurdle's lecture, so of course that's fresh in my mind. It's like, you know, we kind of just, let's throw the book at you and see what works. You know, there's drops, there's surgery, there's glasses, there's contact lenses, and, you know, have you tried everything? So we talk about foveation. Does everybody know what the fovea is? Have you guys all heard about that? The fovea is that point in your retina, in the center of the macula, that we use to see 20/20 vision. Any point off the fovea is less than 20/20. So when you have nystagmus, your fovea is not on that object you're looking at for very long because your eye's moving. So wherever your best vision is typically when your eye movement is moving and it moves across the fovea, that's your best vision, and then you're off of it again. So we looked at that and said, well, how can we get you to use your fovea more? Now, if you have ocular albinism or fovea hypoplasia or macular hypoplasia, The fovea is not fully developed, and so we know you're not going to get 20/20 vision. But for some nystagmus patients, the fovea is fully developed, and you can get 20/20 vision when your retina is on, when your object that you're looking at is actually on the fovea. The problem is your eye's moving all the time, so it's not on the fovea very much. So what can we do to help you with that? So some of the vision therapy that we designed is to sort of train you to use your fovea more. We don't get rid of the nystagmus, but when we look at waveforms, the eye movement is like this. Well, when it comes across the fovea, there's a little flat spot, and then it goes down, almost like an EKG. And so what we've seen with eye movement recordings is that little flat spot gets a little bit longer. The longer you're on the fovea, the better your vision is going to be. And so some of the vision therapy is looking at that. And there's some discussion as to whether or not that really happens. When I was doing my research, we were able to document that we saw some increase in foveation. The bottom line is, whatever your eye movement recordings reflect, it's what you tell me. Yes, my vision is getting better, or no, it's not. And so traditionally for vision therapy, we do vision therapy until we get certain measurements. For nystagmus patients, we do vision therapy until you tell me, I think I've leveled off. I think I've been doing it another 3 weeks and nothing's getting better. Because I've tried to, in the beginning, we tried to stop vision therapy. I said, okay, well, I think this is the best we're gonna get. I mean, we've measured this. And the patient says, well, no, I can still tell my vision is getting better. So we learn from you, and you give us that kind of feedback, and it helps us help the next patient. So for the nystagmus patient, I'm really looking at binocular vision. Are you binocular, and can I get you binocular, and what can I do to get you binocular? So all of the things we talked about for our regular patients who aren't binocular, we do for nystagmus patients. And then we incorporated a lot of sports vision therapy, which is really not about acuity, it's about spotting and reaction time. So you have different parts of your retina do different things. The central retina, fovea, is for visual acuity. Most of your color vision is in the macular area. Your night vision is in the peripheral area in the rods and cones, and your motion detectors are more peripherally located. So you know how you might see a movement out of the corner of your eye and you look and you don't see it moving? Or you might catch the flicker of a fluorescent light. I don't know if has anybody noticed that? You catch the flicker of a fluorescent light and then you look at it, and when you look at it, it's not flickering. And then you look away and you see it flicker again. So that motion sensitivity that you have in the peripheral retina is fired up, and it's noticing the flicker. So it's more sensitive to motion. And so we're utilizing that for spotting and to help you spot. So that's what we do for sports vision therapy. So when you're playing basketball, if you're Magic Johnson, who, one of my favorite players, and some of you might be too young to remember Magic Johnson, but I'm not. So, and I had the privilege of seeing him play live. I mean, he knew where everybody was on the court at every moment. Like, almost felt like he could see behind his head, because if he looked this way, he saw you coming way back there, because he utilized all that motion detection system. So we do that for nystagmus patients. If you learn to use your motion detection system, you can spot things better, because the big concern I get is, I can't, like, if my kid's running, up to me, I don't see him until they get right in front of me, or my friend I'm meeting for, coffee, and she's going, Vicki, 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 and it's not until they're right in front of you that you see them. But if you can detect the motion and you're expecting that, then you're just more aware. So a lot of it is awareness. And using the eye-hand coordination. So when you see that motion, especially for sports, you see that motion over there, first thing you do is you make a move towards it. And that gives you just that instant, faster reaction time. So, so we talk a little bit about foveation tasks. So how do we improve foveation? So it's basically just teaching you how to use it. So we've developed things called dive bombing, coloring in letters, dotting X's and O, line counting, and letter counting. And they seem sort of rudimentary, but they're very basic, and they're things that you can reproduce at home. And it's really designed for you to do home therapy, because you come into the office, we teach you how to do things, and then you go home and practice. It's like piano lessons. You don't go see your piano teacher every day and learn how to play the piano. You go in once a week. They teach you what to do. You go home and you practice half an hour every day. it's that daily practicing that makes you better, not what we actually teach you in the office. So this is kind of small. This is my husband, by the way, who's also an optometrist, but doesn't do this kind of work. So I brought, I don't know if this is any better. So I will pass this around, so if you want to take a look at it. And we do this on white paper and on clear paper for a reason, and I'll explain that. I like X's and O's, and we do them different sizes, because if you can put your pen on the cross of the X, you're looking at it. If you can't, you're not looking at it. If the X is over here and you're not looking at it, you don't really know where it is. I mean, I can get a big target, but can I get I can't really tell where it is if I'm not looking at it. Does that make sense? So for X's and O's, because we have a cross, and you can use anything that has an intersection, X is just easy, that you just go through and you dot every cross of the X. And depending on how well you can do it, how quickly you can do it, and how accurately you can do it, you can train your eyes to use your fovea more, if you have that ability. If you have fovea hypoplasia, it's a different story, but not, a lot of patients who have nystagmus don't have that. So if that's difficult, what we do is we start by coloring in the O's, because it's a little bit bigger target. So just color them, because if you are looking at it, you're going to color within the lines, and if you're not, you're not. And then we also dot, if it's too hard to dot the center of the X, we start with dotting the center of the O, because you have a little bit more flexibility. So we start by just getting it somewhere in the circle, and then we work at getting it more accurate. So then once you can do that, we do something which we call dive bombing, and that is you put your pen next to your ear, you look at the X, and you go. So that's different than having your pen on the paper. Does everybody agree with that? So when you go like this and you're basically spearing the X or the O, then you're spotting it more accurately and correctly. So those are some of the things that Dr. Wick and I developed when I was in Houston. The other thing you can do.
I had a question about the X's and the O's. Do you always use the same font size, or can you start off?
I vary them for the patients. So depending on what they are, I start off with big ones. I might have a sample of. And the beauty about computers, which I didn't have 25 years ago, is that it's easy to vary the size. So this one is much smaller, if you want to pass that around. So you can imagine if your acuity is reduced, it's much tougher. So the better you are, the smaller we make the font. The other thing we do for eye tracking is we actually have you count the number of X's and O's in a row. So when you look at something and it's fairly consistent, it's hard to keep track of. And even if you don't have nystagmus, if you think about like reading a bunch of numbers, 3, 4, 6, 8, 7, 2, 5, it's easy to lose your place. But if your eye tracking is really good, you might have some friends who don't ever have problems losing their place, and you might have friends who always lose their place, and you have to follow along with your pen. So we do that. We use the pen to 1, 2, 3, 4, 5 O's, 1, 2, 3, 4, 5, 6, 7, 8 X's, and so forth and so on. So they're just, what's the word? I equate them to school figures. When you ice skate, you just kind of do repetitive things, and so it just makes those motions and movements more consistent and practiced. Yes, yes.
The X's and O's exercise where you count them, is it done like an XOXO random thing, or is it a row of O's and a row of X's?
Well, if you look at this sheet that's going around, I did a bunch of X's and a bunch of O's and a bunch of X's and a bunch of O's, and you can design it any way you want.
Okay, because I was curious, because I know one of my issues when I'm looking at numbers, and other people with nystagmus have said the same thing, is if there's a whole row of the same number, I have to look at it sideways.
Right, you lose your place. And I'll tell you why you have to look at it sideways. So, and it's okay to do that. And we actually start, it's a little bit ahead of me.
Let me throw something else in there. I don't have nystagmus. I have the same problems. Okay, but I have eye tracking problems.
He has some binocular vision problems too. So.
Which, again, you can have them with and without nystagmus.
Yeah.
But I tracking problems and the whole where's Waldo?
Yes.
Yeah, I got no idea.
So we do.
I might.
So we do, there's a reason why the vertical is easier than the horizontal, and I'll explain it to you, because when you look up and down, so you have 6 extraocular muscles. So, here's your eyeball. You have one on top and bottom. You have one on either side. So they're superior and inferior rectus. Medial and lateral, so you have a medial on the inside here and a medial on the inside here, a lateral here. And then you have one on top and one on bottom, which helps your eye rotate. So when you track side to side, and this is true for every patient, not just nystagmus patients, you have a lateral muscle pulling out and a medial muscle pulling in. So they're actually opposing to do this. And when you go up and down, you have 2 superiors pulling up and 2 inferiors pulling down. So those are the same muscles working with each other instead of against each other. And when you have nystagmus, especially if you have a lateral, because your eyes are going like this, it's very easy to lose their place. So when you turn it this way, you're utilizing these muscles, and that's why it makes it easier. And so some patients have learned to read vertically. So if you just, regular, this is your schedule, turn it this way or you turn it this way. And we do this for patients who have macular degeneration or field loss if they've had a stroke, because when you get to a certain point, you lose it. But you can do the up and down. And if you think about it, you can learn to read this way. I can read upside down. I taught for a lot of years, and so my students had their papers like this, and I came up to their desk, and I could read like this to see what they're doing. I had an instructor in 7th grade who taught me that because he said he could actually read faster upside down than he could right side up because he'd been teaching for such a long time. And we would turn our paper so he could read it, and he would flip it back. So vision is an amazing thing, and the human brain is incredibly trainable. And so if you can read more efficiently this way, I say do it. I mean, it's a great thing to do. And then you just have to try, because some people read better top to bottom and some people read better bottom to top. And I think it depends on if you're more left-handed or more right-handed, which way you like to read. But when we start line counting, which is the highest level of vision therapy we do for nystagmus patients. So think about reading X's and O's. Now think about counting the number of lines that are going across. This is really, really hard. What we do is we start small, like we'll put a dot on one line and a dot on another line and say count the number of lines in between the 2 dots. And when you get really good, you count the lines all the way across the page and see if you can get all the way across and you get the right number. When patients can't do it, we start like this. We say, okay, count up and down, and then we rotate slowly. And we work a week like this, and a week like this, and a week like this until we get horizontal, because most of the world works this way. And so if we can train you to do better this way, this is what we want to do. But we do rotate it, and sometimes we start at a diagonal because we'll utilize whatever you have in your muscle system to help you and then improve the rest of it. So whatever you can do, we're going to take that and improve on it. Mike, you had a question?
Date myself here, but when I was in high school starting using slide rule, I could not read slide rule normally. I could not read the verticals. I would rotate 90 degrees, so I ended up with count 10 players and place out more, with slide rule.
Right, and there's and our position with vision therapy is there's no right and wrong. It's like we find out what works for you, and then we build on that. And so just like no nystagmus patient is exactly like the next nystagmus patient, no vision therapy patient, nystagmus or not, is exactly like the other vision therapy patient. And so we'll try some things for somebody and it won't work, it's too frustrating, they can't do it, we try something else. We don't say, oh, you can't do this, okay, we're done, that's it. So those are, a lot of the things that we do.
So, are these techniques both for improving binocular vision and the spotting skills?
So the line therapy is to improve your foveation. So the binocular vision skills are the things that I went over in the beginning So we do what's not really considered nystagmus vision therapy, it's just vision therapy. We typically don't do this kind of exercise for patients without nystagmus. They don't have the same kind of issues that nystagmus patients have. So we took our basic vision therapy and our sports vision therapy, and then we took it a step further.
Specific for phobia.
Right, correct. And then I was talking to, and I didn't include this in my lecture, but I was talking to a couple of parents at lunch, and it was something that I, after talking to them, I wanted to include. And so, a lot of the kids have issues with sports and spotting and things like that, and we do other sort of in motion type of exercises, and I'll see if I can describe them to you, to help them be peripherally aware. So there's one technique called a Marsden ball. So you take a tennis ball or any kind of ball and you tie it to a string, and then you tie it over the tree in the backyard or in the garage where you have, a lot of space, and we swing the ball front, back, side to side, and then we take a stick or a bat about as long as you can hold, so 4 feet-ish, and we put colored tape on it. So typically we use red, green, and yellow, but I really think you can use any color. I mean, if your kid's doing it, ask them what color they want to do. And we swing the ball, and then we say, okay, with the red tape, hit the ball. So the ball's in motion, and they're holding this, and let's say the red tape is in the middle, then they have to bump the ball at the point where the red tape is, so that you get used to following things in motion and not necessarily looking right at the ball, but having it move and then being able to react to it. So those are some of the things we do. The other thing I like to do in the office is my silver one here? And I'm going to pick on you because you're sitting in the front row.
50 years old, you figure I'd learn.
Okay, so with wolf balls, what I say is, okay, you need to touch my ball, okay, and I'm going to move it. Okay, just so, okay, now, if you're not looking at it, you're not going to touch it.
Yeah.
I mean, you cannot. You want to try it? I mean, it's hard for somebody who doesn't have nystagmus, and then the other thing we do is, okay, touch my ball and leave it there. So, they seem pretty basic, and then you sort of move in ways that you can't anticipate. But, so when you work these skills, you improve your spotting, and that kind of stuff. So that's pretty much what we do as far as vision therapy goes. So you're all here because you've never let anybody tell you this is the best your kids can do. And the big thing is that we do VT until you tell us, I think I'm there, I think this is as good as it's going to get. And I did VT on a nystagmus patient. He started out at 2,200. And he was told, this is the best I can do. He found his way over, and this was when I was doing my internship. He wasn't wearing a good correction. Putting him in the right correction got him to 2080. So that's a huge difference right there. We started vision therapy, and his goal was to get a driver's license, even a restricted one. So he just needed to get to 2070. When we were done with vision therapy, he was 2030. And we stopped as soon as we were like, 2040, you got an unrestricted license? He's like, no, I can tell my eyes are getting better. They're getting better, they're getting better. We continued to do it. We got to 2030. He says, 2030 on a good day, 2040 on a bad day. I think a lot of you know that when you're tired and fatigued, your vision is not as good. And so, the goal of therapy is to give you a longer time before you hit that fatigue. But we went on for what I think was probably 3 or 4 months longer than I would have traditionally done vision therapy, because he kept saying, no, this is getting better. I can tell it's improving. And so I don't tell you when to stop, you tell me when to stop. Yes?
Okay, so something like that, is that like going to the gym and working out, and if you stop going to the gym, your muscles get weak, or do they need to come back?
That is a very good question. The question is, once we get you to a certain point, do you then regress? Do you have to continue to go? And so we do know that when you go to the gym, here's the fun part. In 3 weeks, you start noticing an improvement, right? We see that with vision therapy too. Within 3 weeks, people start going, wow, I think things are getting better. So we get pretty quick results. There are certain conditions, especially in the binocular realm, where you have a convergence problem and you have to pull your eyes together, that we see sometimes that regresses. And it just depends on how much you do in your regular everyday life. If you're not doing a lot of that, we see it regress. And you need to do a little bit of maintenance. But it's not like having to go to the gym 3 times a week for the rest of your life. People feel it regresses. They maybe do exercises for 2 or 3 weeks. It comes back, and then they go on for another 6 months.
Is that because you're now incorporating it into your daily routine?
Yes. It's like riding a bike in most cases. Once your muscles know what to do and can do it, then they're using it. They're, developing it. Now, so the issue comes when you have some suppression. If you have a weak binocular system, it's tougher because there's something pushing you to always use the better eye, and you have to work on using your weak eye. And so in those instances, we do a sort of a maintenance type of thing. And what I find with most adult patients is they do exercise and they go, okay, it's really good. And they're like, okay, I'm not doing it anymore. And then when they get to that point where they feel like I'm having a more difficult time doing XYZ task, then they go back and they pull out their vision therapy thing, so they do it for a little while and it helps. So yes and no. Some people need maintenance. Most people don't. Yes?
Is there an age limitation to the positive effects of therapy?
I don't think so. My oldest patient was 85 years old. But like I tell my patients, there are 85-year-old men and women who run the LA Marathon. I'm from the LA area. I can't run a marathon. I don't know if any of you can. But why can they run a marathon? Because they train for it. And so, I think we have no idea what the human capacity is. And I think a lot of it is mental. If you want to do it, you find a way, you do it. And I thought it was very interesting that Dr. Hurdle was talking about one of the new researchers in the field, that it's mental. We know that meditation and yoga is good for the soul, and it's good for a lot of other things as well. And, we know people can control their heart rate. If you can control your heart rate, it stands to reason that you might be able to control other things. People can control like the movement of food through your digestive system, things like that. It's a pretty amazing thing. I think we haven't even tapped the surface as far as what we can do, what we think we can do. So I don't think there's an age limit. It really comes down to, do you want to do it? And frankly, I don't want to run marathons, so I won't be doing that. Yes?
2 questions that are related. How common is vision therapy, in the U.S.? Are there vision therapists everywhere? And the second one is, how and where then you go about finding someone?
Okay, so vision therapy has been around, I want to say at least 100 years, and for at least 100 years I've been told by ophthalmologists that I don't know what I'm doing, and well, not 100 years for me, but it's fairly common in the US. There are a couple of organizations, COVD, College of Optometrists in Vision Development, covd.org. They have a website. Many of the vision therapists in the United States belong to this organization. I personally don't. I belong to too many organizations and I don't have time for everybody, unfortunately. Otherwise I would be single. My husband would divorce me. They have a list of optometrists all over the country who do vision therapy. Not a lot of them have done vision therapy for nystagmus patients. If you find a good vision therapist, they will be willing to work with you. If you are interested, you can put them in touch with me. Most of what we do is sort of normal, traditional vision therapy, and it's just tailoring it a little bit and going one step further. And every vision therapist I've talked to about doing vision therapy for nystagmus patients went, oh, wow, yeah, we could do that. So if they're interested in vision therapy, they will take it the one step further. And I'm happy to consult with them and just give them, an idea of, where to go. And most of them have taken off on their own and developed other stuff. So it's just finding somebody who's willing to work with you. If you ask your ophthalmologist about vision therapy, they're going to tell you, no, there's no basis for that, and it's not going to help you, and don't waste your money. Rich told me 10 years ago that his colleagues, who are all surgeons, thought he was a quack and said to him, "Who do you think you are, an optometrist?" And he said, and to me, that was a compliment, because that means obviously I'm doing something right. It's making them all a little bit nervous. So yeah, you're gonna come up, you're gonna hit some roadblocks and some people who are gonna say no. And it's really up to you to decide whether or not you think it's right for you. I mean, there's so many different kind of treatments available, and what's right for somebody is not right for everybody. And you know, obviously you're here, so you're looking at everything and anything you can possibly do.
All of the colleges have vision therapy residencies now.
I don't think all of them do. So my husband was saying, don't all the optometry colleges have vision therapy residencies? And I don't think they all do, but they have many. And then there are a lot of optometrists who practice vision therapy who didn't do a vision therapy and pediatrics residency. And they just do it because they got out of school, they saw it, they liked it. They said, hey, I can really make a difference here, and have done it. And so some of them have just learned purely by practicing and taking continuing education classes and doing research. So if you are looking for somebody in your area and you cannot find somebody, you can also email me. Put my email up on the last slide. And let me know what area you're in, and I might be able to point you in the right direction. There was another question back there. I'm sorry, I didn't hear you.
For somebody maybe who's not very coordinated, how can you improve spotting skills? Do you have an easy exercise for that?
You know, we start with bigger things. So the question was, if somebody's not very coordinated, how do you improve spotting skills? Well, we kind of work coordination and spotting skills together. So you can start with bigger things, like you can start with your hand. You know, follow my hand. So if I give you this and I tell you to put it on my hand, that's way easier. Okay, and keep it on my hand and then follow. You know, so you start basic. It's like anything else. When you start therapy, you start at the level that somebody can do, and then you make it smaller, and then smaller. Oh, sorry, I'm coming away from you. I'll come a little closer. Smaller, and then smaller. Here, do my finger now. Okay. And so you just start. You start off with bigger targets. You work your way smaller. Somebody who's really good too. We also use a balance board or a balance beam, or I like a skateboard because almost everybody has a skateboard in their house. Because you don't do visual tasks just sitting or standing, you do it in motion. So we take a skateboard and we roll a towel and we put it on either end so the skateboard doesn't go sliding across the living room floor. But when you're standing on the skateboard and it's balancing like this, I mean, if you try following a target when you're moving like this, now your body's in motion, but your eyes have to stay more stable. And so when you get really good, there are different levels. We just continue to increase the level of difficulty. But we start off, I mean, I do therapy on kids who are, 3 and 4 years old. And so, their muscle coordination is not that good. We just tailor it. We find out what you can do, make sure you're successful at it, and then slowly make it more and more difficult. I keep missing you. Sorry.
My question goes back to what was asked about vision therapies around the country. You said you developed it, you've tuned the exercises to people with nystagmus. How many other vision therapists have across the country?
Probably next to none.
Okay.
Okay. So typically what I do is if I talk to a patient and they're in a different part of the country and they go, I have somebody in my area who does vision therapy and they're really willing to help me, but they don't know what to do, I say, call me. And I only have had to do very little and point them sort of in the right direction. And they've vision therapists are like teachers and physical therapists. I mean, you get a little bit and you're like, oh my gosh, that makes sense and I know where to go from here. And they're just going to do it for you. I mean, I haven't found any doctor who does vision therapy not willing to adapt and, who's not interested in learning more. I mean, we're all students. I constantly go to continuing education classes. I learn something new. I learned something new this morning, which is why I wanted to listen to Dr. Hurdle speak, because there's so much information out there and you just can't know it all. But if you're open to it, But yeah, there's not very many. I mean, there's very few that see nystagmus patients. I think most doctors probably have 1 or 2 patients with nystagmus and say, well, you're doing pretty good. See you next year.
I wanted to touch on something about the prescription. I don't see nystagmus patients on the stairs, no reason why would. Why would, you know? That's what I tell them, you don't want me, you want her. But I do certain other parts of optometry, and I would tell you, we prescribe aggressively. And when I say that, it's typically when we find prescriptions, we tend to give full prescriptions. And a lot of doctors tend to cut back. And when you're talking about somebody who doesn't have nystagmus, maybe that's not a huge issue. I still do, typically, though. And I tell my patients, you know, this may be a little tough to get used to. There are going to be symptoms, you know, you should adapt. If you don't, come back, let me check it. If we need to make an adjustment, we will. I think, unfortunately, some doctors don't want to do that because they feel like maybe it makes them look bad.
I also think that if you have nystagmus and you wear a correction, you might not know if you're wearing the full correction or not. Because as doctors, if we tell you we're not giving you the full correction, now we have to explain why. And unfortunately, a lot of them just don't have the time or want to take the time to explain it to you. So when I see a nystagmus patient and I say, oh, well, you're not wearing your full correction, they're like, what do you mean I'm not? And so you might not know, you might not actually know what your visual acuity is. I was talking to some parents and they said, well, they measure my son's eyes and they say, oh, well, with both eyes together, you're probably 20/50, 20/40. But we can't measure the right eye. We don't know what it is. So they don't know what it is. So they don't even know if he's got binocular vision or not because the doctor's never told them what the vision is in the right eye, which is the weaker eye. And I think that as parents and patients with nystagmus that you might not know as much as you think you know about your eyes because your eye care professional has chosen not to tell you or didn't think it would have any impact on your vision or your lifestyle or anything like that. And so you have to be really proactive and ask those kinds of questions.
Yeah, that's the key. Ask the questions.
They guess.
I'm sorry?
Are you saying that they sort of guess at the weaker
I don't.
Why would they give you the full, what's the best?
So I'm not the doctor and I'm not the parent. All I know is when I talked to the parent, they didn't really get an answer from the doctor. And you know, as parents, we kind of trust our doctors and we go, okay, well, they know what's better, and with both eyes, he's seeing this well, and so that's, you know, that's what we know. And I think it's uncomfortable as parents sometimes to question your doctor. And I have patients all the time who apologize for questioning me. And I say, please don't apologize. It is your right and your duty to question me, to know, to have all of your questions answered, to know what it is you want to know. Maybe, and there have been times when I think in my head, okay, it's this, this, and this, and this, and it doesn't get out this way. I'm writing it in the chart, but it doesn't get out of my mouth because I'm thinking and I'm on to the next thing. And so because I teach, I work very hard at making sure I tell my patients everything, but I do know that even I'm better than most about telling you everything you want to know. I have patients go, oh, don't tell me, I don't want to know that. And so you have to gauge how much you think your patients want to know, how much you think they can absorb. And some patients who are very inquisitive can then take 2 and 3 exam slots, and now it puts you an hour behind, and that's a tough thing to do as well. So typically if I know ahead of time I have a low vision patient or a nystagmus patient, I block extra time because I know it's just going to take more time. When I see kids for the first time, I usually block a little extra time because, you know, as a new parent and you're getting your kids' eyes checked, you want to know everything, you know, because you didn't get that book when you took them home from the hospital of all the questions you're supposed to ask. You know, you just don't know those things. And so when we start talking, then you start coming up with more and more questions. So, you know, we like to give you that kind of time. I'm lucky, I'm privileged that I own my own practice and I can adjust my schedule accordingly. If you work for somebody else or if you work for an HMO, you're given, like at Kaiser, I think it's 8 minutes an eye exam. I don't know if any of you ever had an 8-minute eye exam. It's like this. And you're done and they're like, here's your prescription, see you next year. I mean, it's tough. If you have any kind of vision condition or a vision question, they don't have time to answer them. So, you know, it's your job, and obviously you're doing it great because you're all here, to find out as much information as you can. And you know what, if the doctor doesn't have time for you, said, you know what, I need to schedule a time where I can sit down with you and have all of these questions answered. Or your doctor may say, you know what, email me the questions and I'll email you answers. I mean, however you get that dialogue going, you definitely want to be doing that. But if you don't know what your binocular vision status is and what your acuity is in the right eye, in the left eye, and with both eyes, because as you heard, they're different, you should know those. Okay.
So
Another
what we
question?
will do is we'll let you continue with questions during our break time. And it is 3 o'clock, and I am pleased to make sure we finish on time. And I brought a gift to make it a little easier to finish on time. From
Thank
Anne.
you.
Thank you very much.
Thank you.
Yeah.